Noticing it at 12 years old. I started like shuffling my feet and kind of dragging my feet along. I didn't actually notice it that early, so.
Got it. And then when did you start meds?
14, I was diagnosed with dopa responsive dystonia.
Uh-huh.
But then my condition kept progressing. I had to keep upping my medication.
So it's more than dopa responsive dystonia,
Yeah,
right?
so
Yeah, that was a misdiagnosis.
it was a misdiagnosis.
Because of your age, and you responded well to L-dopa, but you don't have...
yeah, overnight, it was an instant change overnight.
Yeah, because you needed the dopa.
It was so nice.
Yeah. But are we clear that is not the diagnosis?
Correct.
Yeah, okay. But that's not. Okay, and then age 18, you started with Silky Pressol.
Yes.
And your current medications are... What are the symptoms that are interfering with your life?
Just like getting stiff and having a little bit of tremor like throughout my full body. But like the worst case scenario, I can't walk. Like just even when I think today wasn't even at my worst. Like my feet get so shaky, like kind of like this. And I think I get dystonia in my feet because they're like pointed and I can't unbend them. It's like a really full body thing, and I can't, like, at my worst case scenario, my worst day, like, it feels so, like, heavy in my brain, like, I can sit up because I'm quite strong.
Can I interrupt for a second?
Yes.
Is that when your meds are wearing off?
Well, even my medication, I was on it all day this morning, but that's how I feel when my medication's wearing off. Okay.
When you get that feeling, that horrible, I'm stiff and shuffly and dystonic and that, can I call that off?
Yeah.
I feel off.
Did I say?
And no, I'm sure you did. And then when you take your meds, when you're off, do you feel your meds kick in and then you come back on again?
It takes about 45 minutes.
Or variable, depending on
totally
how much protein is in your stomach and all that. But you you respond to your meds.
Oh yeah, I can. Yes.
When you are at your best on.
I'm like, nobody knows I have anything different.
Wow. So like no balance issues.
I do CrossFit. I don't know if you're familiar with that. So okay. Just a strength issue. But yeah.
Yeah. So when you're good, you're really good.
Yes.
And when you're bad, you're stiff and frozen and shuffling and.
But it's like it immobilizes me, basically.
Got it. When you are, and this is a hard concept. So there's on and there's off. When you are off, is there an emotional off as well? And this is an important concept for me. Every human being on the planet would be angry, frustrated, upset with the disease as it's off. I can't wait till the darn medications kick in and okay, I'm good again. Or that would be called, then I would have thought, a normal emotional reaction to being off.
Yeah.
Some Parkinson's patients have more than that. Oh. They get a blackness, sadness, overwhelming. The clouds come in. It's like a profound, we call it anhedonia, but it's a deep sadness, suicidal ideation, just leave me alone. Mm-hmm. It's more than just the frustration of being off your meds. Do you get that at all?
I don't feel like I can relate to that.
Okay, so I don't want extremes. I want
routine.
The routine. You've had when you have a bad off and the legs are doing that.
Yeah.
What are you feeling emotionally at that time?
Well, like on a totally normal day, because like it happens like 3 to 5 times in a day at least. Yeah. I just get bored because like I can't do anything.
Okay,
so
fine.
I'm pretty good.
That's what I'm wondering. You're not inevitably getting a change in your emotion as well.
Yeah, I don't cry like every time like I used to, but I kind of got over that, and I'm getting more patient with it.
Waiting for it to pass, waiting for the meds to kick in.
Occupying myself as much as I can. So yeah, on a normal day-to-day, hour-to-hour basis, I handle it okay, I think. But then on the...
Okay, I think I'm getting it. Anything else? Any other symptoms? Do you have cognitive symptoms? Or have you taken a hit intellectually because of this disease?
I think I'm just... No.
I think there's brain fog.
When I am off,
you're off, I appreciate that.
Yeah, when I'm off, I have trouble focusing.
And you're slower to come up with the answer, although you might get the answer eventually.
And I get flustered a bit more, kind of a little bit. What's the word I'm looking for? I don't know what the
Well,
word.
sometimes when you're working on something, you say, well, I can't focus right now, so I'll do this later.
Yeah.
Now, when you're on and at your best, how's your thinking?
I think it's pretty average.
You felt it's okay.
What is it based
I
on?
know.
Memories are horrible. Yeah, I don't have a good memory.
Okay.
Yeah, I have to write things down all the time.
Medication, but there's definitely a memory
Forgot about that one.
Of course you did. So you haven't lost your sense of humor. But you could be left at a mall and know how to get out of the mall.
Yeah.
It's not like, oh, we can't leave her alone.
Little thing. Not
You okay?
for things that were setting conversations and stuff like.
I'll forget if we watched them.
No plans and.
But would you? It has not reached a point where you would be uncomfortable allowing her to write a check.
No.
Allowing her to buy something over the internet.
No.
Has there been any inappropriate behavior in response to the medications? Organizing things, obsessive compulsive.
That's just me, though.
Well, I don't know. The only thing I would say is
you can say it.
I mean, I think she. I don't know if this is it or not, but she'll like organize the house in one way.
Yeah.
Everything is fine, and then she'll immediately a week later she'll organize it another way.
Okay.
In my head, I just feel like there's a better way it can
That's
be
the
done.
only thing.
So I feel like it's a practical sense, but I don't know.
Do you think that is interfering with her life? Or no, that's just what she's doing.
It's just
It's interfering.
it's interfering with the cleanliness of our home right now.
Yeah. Okay. So you're not gambling. You're not on the internet compulsively buying. You're not out of control.
No.
You're in control.
Yes. I think the way that the organizing does interfere with my life is like I want to get it done before I go to bed, but I know there's no way I can get it done before I go to bed, so that's why I stay up so late. I don't know if that's interfering.
Yeah, so do you stay up and do it?
Yes.
And hurt your sleeping?
Yes.
You can't let it go.
Almost every night.
Yeah, so that's a little obsessive compulsive because it's probably in your best interest to sleep.
Totally.
And then maybe attack it the next day, but you can't let it go. Okay, do you
But
have problems sleeping?
No.
Does she fight her dreams?
I scream myself awake sometimes.
Yeah.
Is she fighting her dreams? Is there a movement like she's struggling and fighting, or she just screams out?
There's not movement. I think it's
Okay.
more screaming.
Yeah. Okay.
Yeah. And the thing with screaming myself awake, I feel like I can feel my symptoms coming on, so it turns whatever I'm dreaming into a nightmare.
Oh, because it's as if someone.
So it's I'm I can't
Yeah.
run, and then I can
Yeah.
feel myself.
So do you have trouble getting through the night then because of your symptoms?
If my pills run off, then
Yes.
I'll wake up.
Tight.
Yeah.
Is there a pain associated with the tightness? Is it so tight
It's
it's
just-
like a sports Charlie horse?
It's just uncomfortable.
Okay.
The only
You
time
describe it as pain sometimes, though.
it's painful when it's on for so long, it starts turning into a cramp in my calves mostly. But sometimes it gets I'm uncomfortable all the time when I'm off, and sometimes it's I can't bear it. It's just depending on how long I've had it.
What about when you've said that your toes feels like it's going to
Oh yeah, my toes look good. When the dystonia is so bad, they
The
feel
off,
like they're
we're
gonna
talking off?
yeah, when they feel like they point outwards and they feel like they're gonna fall off.
Outwards?
Outwards.
They don't twist in?
No, so my toes go outwards and upwards.
Your toes go up and out, but your foot goes in.
Yes.
With your foot turn in like that.
It's
Yeah. And then the toe
like
goes
that.
up and out. Yeah. That's a dystonic posture. And then social history, you're married.
Yes.
When did you get married?
2014.
Any kids?
No.
You don't. Do you have this symptom? I am really good. No one knows I have Parkinson's. Holy cow! I just froze. I can't move. I can't move. I can't move. I came back on again. 5 minutes
No.
later, I'm okay again. Ooh.
Is that?
So I don't do pills. I just do the surgery for Parkinson's disease.
Yes.
And the surgery is called Deep Brain Stimulation.
Yes.
And everything that I talk about is on our website.
Yeah.
DBS. We think ST and DBS kind of works like DOPA. But the beauty is that it's on 24 hours a day.
Yeah.
It's not waiting to be absorbed from your stomach, coming into your blood, perfect concentration, maybe too high, I've got dyskinesia, perfect concentration, and wearing out before the next pill hits you again. So anything DOPA can do, ST and DBS can do. So if you're a good responder to DOPA, you typically be a good responder to DBS. So I think of my job at the beginning is trying to give you an idea what your life would be like if you had ST and DBS, because you can't know. And then also tell you And these are the risks of me doing the operation. Now over to you. What do you think as a family?
Mm-hmm.
So I have to then do my best to imagine what would your life be like if we had operated on you last year and everything went beautifully. And the best indication that we can do to that is if you respond to the DOPA, then you'll respond to the STN. If you pick your best moment last week, we can capture that and drag it out all day. If your best moment last week has problems, you will have problems after our DBS. If you have cognitive issues, emotional issues, swallowing issues, balance issues, speech issues that don't respond to the DOPA, it's not going to respond to the DBS.
Mm-hmm.
If you have good movement in response to the DOPA, you're going to have good movement in response to the DBS.
Okay.
So the only thing the DBS has better than the DOPA is that DOPA is doing this, and so are you. And the DBS will do whatever we want. So if we turn the DBS too high, you'll be dyskinetic 24 hours a day. If we turn it down too low, you'll be frozen all day. But there must be a sweet spot where we could turn the stimulator and then just leave it there. This is an implantable neural stimulator.
Oh.
But the platinum electrodes go into the brain, into the subthalamic nucleus,
Okay.
and then the power comes from here, which we can, or sometimes in young ladies we put it sort of down in their belly for cosmetic reasons, or if you want, and then it will drive the stimulation into the nucleus and give you the benefit from the stimulator. If you need more stimulation 3 years from now because your disease has progressed, you come into the clinic, click, 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 through your shirt, we just turn up the stimulator a little bit. If you find that the stimulator is giving you a side effect and you don't like it, click, 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 we turn away from that. And so the strength of the DBS is that it is, we call it titratable, up, down, up a little more to an individual person, not to the general population. We will individualize, we will tailor the therapy to what you need, and we will probably change that over your lifetime because you will need more in 10 years than you did today.
Mm-hmm.
So that's it won't make you better than your best last week, your best moment last week. It can't do that, but it can typically capture that moment, and because it's just rock steady 24 hours, including while you're sleeping, it'll just keep you there.
Wow.
So in response to that, so it's as if the background level of DOPA has been lifted up. Okay, you can't now take all the medications you're taking because you'll be dyskinetic every 30 minutes, right? So there'll be a dramatic reduction in your oral medications, probably not to zero, although some of our patients do go to zero, but it will probably be dramatically reduced, so you're taking much less. And so when you're taking less medications, you'll be fluctuating a little bit less. Does that make sense?
Yeah, so
Probably will still be fluctuating somewhat if you're taking oral meds, and most people are taking oral meds.
Yeah. So will it go back to the Cinemed or to the regime she's on now?
We'll probably simplify it down to Cinemed, but because you don't need the entecapone holding you up and the pramipexole, but that is also very individual because some people, we pull them off their meds. Oh, I feel a sadness off this meds. Oh, because that medication was also feeding the limbic emotional circuits as well as your motor circuits. That's what I was trying to tease out when your meds are low. Doesn't sound like you have that, in which case we'd be free to get rid of it. But I have had patients who back off on their meds. They don't like it emotionally. They're moving around beautifully, but they take an emotional hit. We have to put them back on that meds just for the emotion to keep them stable. But I don't think you have that. I don't think you have that. So that's the good news. That would require full-on brain surgery and then follow-ups with the DBS clinic. Initially a lot to fine-tune you, but once we get you set, every 6 months or a year, whatever you want, you come back and, hey, how's it going? And, oh, do you think you need a little bit more or not? And 5 years from now, you know what? Looks like your battery's running low. Can we flip in a new battery? Not brain surgery, but you need a new battery. And then there are risks of doing surgery. A human being is going to do the operation. I've done 500. I've never had a death, but that's very unusual. The death rate's about 1% around the world. I would say your risk, even though I think your risk is probably 1 in 500, I say it's 1 in 100, just so that people can wrap their head around it. 1 in 100 chance that I'm going to hurt you. It's probably way less than that. So there's I'm going to say a 1 in 100 chance of a catastrophic injury, changing both your lives for the worse. Then there's probably a 3% chance of some kind of complication, but we'll fix it. That would be like an infection. You're not supposed to get an infection, but if you got an infection in your skin, I'd give you antibiotics until I fixed it. If a wire ever came loose, I'd fix the wire, or wire ever broke, I'd replace the wire. Those are all definitely complications, but it's not going to change your lives. It's my job to get you around it and get you back on course again. Doesn't happen anymore, but 4% of our patients had psychological changes following the stimulator, this bizarre behavior. Similar to Mirapex, where they get this it's called hypomania, but you're just high. The patients love it, but they do absolutely inappropriate things. Like, I had a patient who was walking down the street, saw a beautiful car, and thought, yeah, I've always wanted to sit in a Mercedes. And he just got in the car. And he wasn't going to steal it. He wasn't going to, but he thought, this is really nice. I've always wanted to do that. And the police came and said, excuse me, what the hell are you doing? And he said, I'm just enjoying this car. So he was not quite right. And it was not appropriate. He would never have done that.
Yeah.
So we don't do the surgery anymore on people who live by themselves. So when you come for the clinic, the nurses, the first thing they'll say is it her? And you'll go, yeah. Because if there's a behavioral change, you'll notice it instantly. And the only danger is you didn't tell us.
Is there anything that they wouldn't be able to do the same that they do
No.
now?
Apparently, there's no restrictions.
Like swimming, I guess, is not
Yeah.
an issue.
Yeah.
So Hillary's worried too about weightlifting too, because sometimes she dropped the weights on her body.
Like the barbell would sit here in CrossFit.
Yeah, you're going to decide. The goal is not to restrict you, but to allow you to live your life. What we have always tried. We've never had someone quite so young for Parkinson's, but what we have always tried is, please forget that you have Parkinson's and get on with your life.
Yeah.
Stop looking at the device and worrying about the device. We normally put in, we're called primary cells, which is just a battery, which you just forget about it, and 4 years later, I'll replace it. But there are rechargeables that last much longer, like 10 years. And the other thing is, we're not burning any bridges. They come in with a stem cell transplant or something like that. We'll just take them out. We'll take your platinum wires out and throw them away. It's not like we burned any bridges or anything like that. So it's reversible is another concept. Yeah. So a couple things is we want to evaluate you before surgery. Not today, but my nurses do that. And you get a formal UPDRS evaluation, so you come in off your meds. Not having taken meds since midnight.
Before the surgery?
No.
This is a completely different day.
Completely different day. And you are off. And we videotape you off. And you try and walk, and you try and draw circles. And then you take your meds. And when you kick in, you're videotaped again doing those same sort of things. And if there's a big difference between them, you're a great candidate for surgery. But I haven't seen you off. I believe you, but I'm not prepared to operate without truly understanding you. And then the nurses will also do an IQ test and a mood test and these 5-minute tests to make sure I'm not missing anything. And that's always, so you come off, so that's a tough day for you because you probably come in on your, come in a wheelchair or whatever, and you're off, and then we might ask you those questions about how are you feeling, and then, but at 9 o'clock the nurses will see you, and then by 9:30 you take your meds, and by 10 they've kicked in and you're out of here.
And so,
That's one.
oh, sorry.
Second, the day of surgery is the same thing. You're off your meds when we do it and you're awake.
Yeah.
Now, we can do the surgery with you asleep if it's just impossible. I mean, we put the 5-year-old to sleep. There's no way he's going to, right? So we can do it with you asleep. I'd rather not.
Yeah.
I'd rather do it like I do everybody else, with you awake, and then you can guide me physiologically into the right target.
Okay.
But it's a tough day to be off your meds.
Yeah.
And there are some patients who just can't do it. They can't breathe. They can't, you know what I mean? They can't stay off their meds for 8 hours.
It's probably best to be awake because I remember during my dad's scan, I don't remember how long I was off my medication for. Like I felt my head started to like go backwards because my neck was cramping up. So
Yeah.
she started massaging my neck too.
That helped.
So yeah, that was something.
Well, that's a very important pragmatic issue. Are we going to be able to have you off meds for, from midnight till 3 in the afternoon? And if the answer is no, then we need to figure that out and do you asleep.
Yeah. So
the asleep is okay with me. I've done it before. It just doesn't mean I'll lose the ability to turn the stimulator on and say, how does that feel? Do you feel any side effects? And you'll say, I don't feel it. Okay. How is that stiff hand of yours? Let me turn it on. Oh, wow. It must be in the right spot because you're loose now, even though you've been off your meds for 8 hours. And while the stimulator is on, are you having any side effects? No. Oh, perfect. That must be the perfect place for you. Lock that one in and then go to the other side. So if I have my choice, I'd like that ability to confirm physiologically with a patient. Sure, you'll be under local anesthetic. So the halo will be locked into your skull, but it'll be frozen. You won't actually feel it. You go back on your meds at the end of the operation.
Okay, good.
And then you probably go home like a day or 2 days after surgery. You go home on your meds.
Okay.
Stimulator is turned off. It's just in there, but it's turned off. And then we wait for you to get back to baseline, and you usually come in and see the nurses about a month after surgery.
Okay.
And a month after surgery, when you come in, maybe that one day, they're going to ask you to stay off your meds so that they can test which is the contact that most loosens you. And then every week for a couple weeks, stimulator up, meds down. Come back. Stimulator up, meds down. Stimulator up, meds down until they find the sweet spot for you. Okay, see you in a year.
And then like how soon after I go home would you recommend resuming normal?
You're not allowed to do anything strenuous for 6 weeks, and strenuous is where you would naturally grit your teeth to do it.
Okay.
So if you can pick up a bag of groceries and not, but if you're going,
so I can't.
If you're doing that,
Yeah.
we wouldn't want you doing that. So like literally lifting a weight
So
where you gut it out. We wouldn't want you to do that for 6 weeks. It'll give you a wicked headache.
So like going for walks would be okay.
Perfect, but not maybe a run.
Yeah.
Nothing where you would fall, like not rollerblading, not maybe bicycling, but a 10-kilometer walk would be fine. Like even up like a hill, and you get your heart rate up.
Yeah.
That's fine by us, but we don't want anything where your head might be inadvertently hit because you fell off something.
And what would be like an estimated timeline for when I would get to go and see the nurses, and if we were.
So the nurses will see you very quickly. The MRI scan people would see you tomorrow. What we'd want is you to think about it. Once you think about it, then I would urge you to sign up and get on the list, because if you wanted surgery today, you're still waiting. I don't like to give out numbers and that, but like a year or something. What sometimes happens is no one ever decides not to have surgery. That would be unbelievably rare. But sometimes they get the flu, or they get an appendicitis, and they can't keep their date, and their spot becomes open, and we parachute people in. And so we can only parachute people in who are totally ready, i.e. you've had your blood tests, you've had your MRI, you've done your UPDRS, your package is completely done, and you're sitting waiting. And then we would give you, boom, you could sometimes jump the queue a year because, a spot comes open. Yeah, you didn't wait that long to see me.
2 years.
Yeah. So normally it's 4, but I bumped into Silky and she told me about you and we just bumped you up. So yeah, I wish it had been more than, you hadn't waited 2 years, but whatever, I appreciate that. Yeah, my pleasure. So yeah, no, it's, the nurses do not have a long wait list. Yeah, and I would encourage you to coordinate it with that, and then we have another meeting about you. You're not there, but we talk about what she looked like, what was she feeling, whatever, and what's the mood, and we just, and everyone then says appropriate for surgery, and then I make the final decision. And yeah. So based on your story, you're a perfect candidate for us. Young, healthy, and you got these on-off fluctuations. We'll smooth you out. You might have a very good response in terms of quality of life. Yeah, that's what we would do. Anything else? Yeah, so on some of our patients, we've been very selective. Like the older people, but the younger ladies, we try and minimize hair. Yeah, but I do need to take a little patch, one on the left and one on the right. Try and leave the bangs in front, and you could wear a Jackie O, like scarf over the top or something.
That would be much appreciated.
Yeah.
So we just talk to your receptionist to try and hook up with the nurses then?
Are you interested?
Well, I'll let Hilary make the final decision, but I think she's thought about it a lot already.
Oh, wonderful. No, I'll just put it in my letter, and then nurses will know instantly as soon as the letter's dictated, and then they'll contact you.
Yeah, I think if I'm a candidate, I don't want to stop any of this procedure on my part.
So you're okay on our side of the desk. Now it's over to you. Here's the benefits, here's the risks. You have to decide on your side of the desk. Yes, please. No, thank you.